central nervous system or CNS abscess and various diseases, brain abscesses, and the neurocutaneous disorders. Although it might seem obvious, it's important to remember the brain abscess specifically means a collection of infected material within the brain parenchyma itself. This acts as a space-occupying lesion within the brain. Now, the reason why that's important is because there are rare but subdural collections of infection, epidural abscesses outside the dura. And the reason why it's important to distinguish them is because the bacteriology is different. If the bacteriology is different, the treatment is different. So that is why the distinction between intraparenchymal abscess and one outside the parenchyma is enormous. You might say at the beginning, well, aren't they all in the brain? Aren't they all inside the skull? Aren't they all inside the spine? Yes, but a subdural empyema and epidural empyema are staphylococcus, and one's inside the brain is 2/3 anaerobes, and that's a huge difference, isn't it? It spreads from a contiguous infection. The other abscesses, subdural and epidural abscesses, are spread by the blood. It starts out, the brain abscess, in the sinuses, the mastoid air cells, otitis media. It's a very rare complication, but it can spread inside. And any bacteremia could go inside. Pneumonia and endocarditis cause bacteremia, and that's simply why they're some of the most common reasons to cause a brain abscess, simply because these are two of the most common reasons for anybody to have a bacteremia. Remember that the most common reason, though, is just it spreads from a contiguous infection. Now, you'll notice that the sinuses, the mastoid air cells, and otitis media that fails therapy with amoxicillin are going to always need a precise microbiologic diagnosis because they could be mixed infections and have anaerobes and gram-negatives, and that's the key to this entire section. Know the microbiology. How do I answer what's the most likely diagnosis? Well, you have a headache, nausea, vomiting, fever, seizures, focal neurologic deficits, and there is just no way to distinguish a brain abscess from cancer without a biopsy. You see, cancer gives fever too. Cancer fever. Now, you can only call it a cancer fever when you exclude all the other potential causes of infection. You see, it's a diagnosis of exclusion. Now, you may be on your rotations, and remember that this device could be very nicely used for your shelf examinations. Use it on your rotations. Repeat it later on. So if you're on your rotation and your attending swears that you can tell by CT and MRI a brain abscess from a brain cancer by the radiologic appearance, don't disagree with them in person. Just answer what I tell you on your test and you'll be fine. The best initial test for a brain abscess is a head CT or MRI. Remember, the thing that tells you that it's there is somebody has focal neurologic findings or they've had a seizure. So even if you had no idea whatsoever there's a brain abscess, the focal neurologic finding or seizure will tell you, best initial test, head CT or MRI. Most accurate test is a brain biopsy, because that's the only way you could know for sure the content of it. Now, CSF evaluation, cerebrospinal fluid, not only would it be unlikely to be helpful, even if it were obtained, the LP is contraindicated. It's dangerous because of the possibility of herniation. You're going to be like, on the rectal exam, oh, that's a nice smooth prostate you have in your rectal. You'd be like, excuse me, it's not my prostate. I've herniated. That's my pons. So you're going to look for this ring or contrast-enhancing lesion after people present with fever and a headache and a fever, focal findings, and or seizure. The scan with the ring or contrast-enhancing lesion has surrounding edema. That's the dark stuff. And it's that dark stuff that gives the mass effect. It's the mass effect that with the lumbar puncture can cause the herniation. Cancer and infection are indistinguishable based on the imaging study alone. You've got to get a biopsy. Now, you may be the only person on your rotation tomorrow. If you're on a rotation, you hear this, and they want to just treat someone empirically with intravenous antibiotics for 6 weeks. With the exception of HIV, where it might be toxoplasmosis, If the person's HIV negative, you must tell them to biopsy. The biopsy is essential because only the biopsy can distinguish the abscess from cancer. It's the only way to know the sensitivity of organism, and abscesses can be staphylococci, streptococci, gram-negative bacilli, anaerobes. And not only that, it's frequently mixed. It's polymicrobial. It's frequently mixed. And after all, would you want to be able to treat for 6 to 8 weeks intravenously, only to tell people, by the way, you're going to do 2 or 3 more months orally and say, gee, I'm sorry, those antibiotics don't work for glioblastoma multiforme? No. It's 1/3 staph, 1/3 strep, 1/3 gram-negatives, and 2/3 anaerobes. That's a lot of thirds. How do you get to 5/3? Get 5/3 because it's mixed polymicrobial. Empiric therapy is okay as long as you know that penicillin, metronidazole, and ceftriaxone, or cefepime, are not a substitute for long-term treatment without a biopsy. Penicillin is for the streptococci, metronidazole is for the anaerobes, ceftriaxone or cefepime are for the gram-negative bacilli. Vancomycin is an alternative if somebody has a life-threatening penicillin allergy, or if there's been neurosurgery. Remember, neurosurgery means staphylococcus. Cut the skin into the brain and there's staphylococcus. But biopsy for culture is indispensable in a precise diagnosis and treatment of a brain abscess. You've got to avoid prolonged empiric therapy. You will never be able to construct an empiric regimen that will cover all the patients. You've got to get a sample. Neurocutaneous diseases are unusual disorders. Tuberous sclerosis, neurofibromatosis, and Sturge-Weber are rare, but they're not rare on the test. We make you learn them because they are frequently asked. That's it. It is faster to learn them than to complain about it. In tuberous sclerosis, the neurological abnormalities that you will find are you can have seizures, and some people get slowly progressive mental deterioration. Now, each of these has a characteristic skin manifestation. Adenoma sebaceum, reddened facial nodules on that tuberous sclerosis. Shagreen patches, wow, leathery plaques on the trunk, and ash leaf or hypopigmented patches. And you got to learn it, the retinal lesions and rhabdomyomas. Rhabdomyomas are benign muscle tumors. Now, there is no treatment, and at most, all you can do is control the seizures, but it's a question of recognizing what's the most likely diagnosis. And in addition, you're going to have to know that adenoma sebaceum goes with tuberous sclerosis, and Sjogren's with tuberous sclerosis, and ash leaf with tuberous sclerosis, and that's the questions you're asked. Neurofibromatosis are soft, squishy, and look the same exact color as the rest of the skin. And that's how you tell it apart from something like seborrheic keratosis, which is hyperpigmented. Now, there's also eighth cranial nerve tumors, and that's why you can get bilateral deafness, because it is like an acoustic neuroma. It squeezes your eighth cranial nerves. It goes through the canal. It squeezes it and gives you ringing in your ears and a hearing loss. Vertigo, nystagmus, ringing in your ears and hearing loss. These café au lait spots, which are strange hyperpigmented lesions, and meningioma and gliomas. And by definition, a meningioma is benign. They're all benign. They don't convert into skin malignancy. They don't convert into a glioblastoma. You live your whole life with these lesions, but they don't kill you. Unfortunately, we don't have a specific treatment to stop, retard, delay, or impede the progress of neurofibromatosis. We only can manage sometimes the eighth cranial nerve lesion, where you might have a surgical decompression to preserve your hearing. You're literally shaving off the lesion from around that eighth cranial nerve. If I had this, I would be tempted to slice off the skin lesions. It won't work. They're going to grow back. It's only going to make it worse. So you may not like it, but the answer is no specific therapy. Now, Sturge-Weber syndrome is a port wine stain in the face. There's seizures and CNS abnormalities, homonymous hemianopsia. That's where you lose half the visual field of each eye. You will not detect that unless you do detailed eye examinations and visual fields. You can also have paralysis of one half of your body. You may be wondering, by the way, what is the difference between hemiparesis or hemiparesis and hemiplegia? Well, one is worse than the other. Which one is worse, hemiparesis or hemiplegia? The one that's worse is hemiplegia. So hemiparesis is what you get in Sturge-Weber. And hemiparesis just means it's weak, but not paralyzed. There is some degree of mental subnormality. So tuberous sclerosis and Sturge-Weber are more likely to have the mental subnormality. And the unique physical finding, of course, is that port wine stain. The X-ray of the skull will show calcification of the angiomas, and unfortunately there's no treatment except control those seizures.